in their lives. Where do you see this going, Nick? Like, I feel like
Mhm.
you're. I mean, my bias is not everyone's seeing this the same way, and maybe they are. I don't know. You're closer to it, but where do you see this going in terms of therapeutic options for patients?
Mhm. I think this area will continue to develop, and as I mentioned, beyond exercise, other lifestyle measures, so things like diet and even optimization of sleep, I think will continue to grow. Out of the three fields that I mentioned, exercise is probably the most developed right now, but the other ones are quickly catching up with different RCTs and things like that. I think the issue stems from what we discussed at the beginning of this episode, where we as physicians, regardless of specialty, you are taught that exercise is good for so many conditions, whether it be physical or mental. But speaking for myself, in medical school, I was never taught how to prescribe exercise or how to talk to a patient about getting into it. Which I think if we take a bottom up approach, once we have the evidence base for its effect, this should be something that's taught in both medical school and residency to a level where we're able to speak to patients. Like in my psychiatry residency, we do a lot of interviewing techniques, etc., prescribing different drugs. I have a textbook over here beside reading all the mechanisms of different things. But in all these textbooks, we don't really talk about exercise beyond, oh, it's good. Same with diet, oh, it's good. Like, and that doesn't make it conducive for someone to be able to feel confident to talk to a patient about it. And there's been research on that too, not specifically within psychiatry, but looking at family physicians and those who exercise themselves were way more likely to counsel their patients on exercise, and those that didn't weren't. Now, that could reflect their own bias, but it could also reflect just not being comfortable talking about it with the patient, which I think our training we should leave our training feeling comfortable discussing first line options. And where this goes further for the field of psychiatry, in our current guidelines, so CANMAT guidelines, that we follow, we study for our exams, exercise is actually a monotherapy first line for depression. But when I tell that to a lot of people, people are surprised, like even in psychiatry. So I think we need more. We have the evidence, but we need to spread the word and teach people how to speak to their patients because it is one of the treatment options. Because as I mentioned before, we oftentimes look at treatment from a simple lens of meds or therapy or both. But there's so much more in between. I know we're mostly speaking about exercise, but there's room for optimization of someone's diet. And that goes to the metabolic side as well, too. There's room for optimization of exercise and sleep. And all of these things contribute to the symptoms of depression, schizophrenia, anything. They're all kind of intertwined. And sometimes I think that our approach currently is very much kind of like a band-aid solution where you're giving someone a medication which helps, but doesn't solve the underlying pathology or what might be going on to perpetuate that illness.
Honestly, Nick, I'm finding this conversation so encouraging because one of my concerns in healthcare and medical education right now is we don't have we rarely ask ourselves what's the root cause, like what is actually happening, and how can we